Good evening, delegates and participants. Thank you for joining Shield Connect. And today, Northeast Association of Obstetric and Gynecology Society of India invites you for the webinar on high risk pregnancy. So, before we start the webinar, let me introduce our conveners for today, Dr. Indrani Roy and Dr. Deepti Goswami. So, let me introduce Dr. Indrani Roy. Ma'am is senior consultant and HOD in obstetric and gynecological department in Nazareth Hospital from Shillong. Ma'am is past president of SOGS from 2017 to 2019. Ma'am is organizing chairperson of EZYF 2019. Ma'am is East Zone coordinator of press committee 2019-2021 and DNB teacher. And let me also introduce our other convener, Dr. Deepti Goswami. Ma'am is secretary of Guwahati Obstetric Gynecological Society. Ma'am is senior consultant in Dispur Polyclinic and Hospital and Aditya Medicity. Ma'am has experience of 16 years in this field. Ma'am has completed MBBS from Assam Medical College and awarded as a gold medalist in her MBBS. Ma'am is member of Assam Medical Council and also of Indian Medical Association. So I welcome Dr. Indrani Roy and throw the session to you, ma'am. Thank you, ma'am.
Thank you, Nishan, and a very good evening to one and all, everybody present here today. A hearty welcome to all of you for this academic webinar on high-risk pregnancy, which is being organized by the Northeast Obs and Gynae Societies. And it gives me immense pleasure to host this webinar today, and where we have a galaxy of faculties today, starting from Sadhana Gupta ma'am, Shashwati ma'am, Nilakshi Maido, Puroshri. We have moderators as Tanma with all her team of panelists, esteemed panelists, and I'm sure today we are going to gain in a lot of knowledge and experience by hearing to the learned faculties today. So to start with, we have the traditional auspicious lamp lighting ceremony during this unprecedented times with the pandemic hovering over us. Though we are just coming to an end, but we don't know what is going to happen. So I'm sure we believe that the lighting of the lamp, this auspicious light and brightness, will be equated with positivity and motivation. So can we have the inaugural slide, please? Thank you, Chitra. So thank you so much. And now it gives me great honor to introduce the chief guest for today's webinar, Professor Gokul Chandra Das, who is a friend, teacher. He's a teacher to every one of us, and now he has become such a good friend. I'm really happy to introduce you, sir, today. So he was a professor and HOD department of OBGY at Guwahati Medical College, and he was also the founder, professor, and HOD at TRIMS, Naharlagun, Arunachal Pradesh. He was the officer on special duty, Shrimanta Shankardev University of Health Sciences, Assam. He was the vice president of FOXI in 2014. He is the president of the Northeast Association of ONG Societies. He was the organizing chairperson of ICOG Guwahati 2010. He has delivered numerous guest lectures, panelists, orations, and lot of publications also. Sir, welcome to this webinar today, and your thoughts and blessings to start the session today, sir.
Good evening, and I really appreciate the word friend, because that's how I want to be remembered amongst you, that I'm more of a friend than a teacher. That's the exact word that I would like to be remembered for the rest of my life. And it's a very nice conference. I mean, the topics are very nice. Preeclampsia is a burning issue in this part of the country. So we'd really be enlightened by the views of Dr. Sadhna. And then induction labor, let us see what new things have come up. And PPH, always a scenario which needs so much of discussions and everything. And young generation speakers will do great justice to it. With these three words, I welcome everyone to this webinar and wish all of you the best of everything. And thank you very much.
Thank you so much, sir, for your kind words. And may I now request our guest of honor, Dr. Arun Madhav Barua, sir. Sir, can we have his slide? He is the chairperson, Northeast ISAR. He is the chairperson of Northeast Association of Gynecological Endoscopies. He is the managing committee member of IH 2018 to 2020. He is the secretary of Northeast Association of OBGYN Societies, and he is the president of the Dibrugarh OBGYN Society, and he is the coordinator of IH Eagle project. So sir is known to all of us, and he has been very popular amongst all of us. So sir, your thoughts and words for this session today.
Good evening, Indrani, to all others, those who have joined in. I think webinar has its own importance, and as Gokuldas rightly said, Sir has been a lighting force for all of us, and webinars has been a lighting force during the pandemic to all of us to keep us en route to our knowledge. High-risk pregnancy has been the need of the hour, and we have tried in the various forums to bring the importance of high-risk pregnancy amidst all of us. We know high-risk pregnancy today deserves a very special place because the critical care in obstetrics has also developed, and what we are more familiar with today is the high dependency unit than a critical care unit or an ICU in obstetrics and gynecology. As there is nothing called low risk, but obviously the high risk pregnancy is going to stay, and the importance of this high risk pregnancy needs to be appreciated by every consultant right from every part of the country. And this is more relevant in this region because we have to deal with a situation in a scenario where the infrastructure and the facilities or even the support staff are not fully trained, and we have to perform in odd hours in odd situations. So enlightening ourselves with the knowledge and the possibility that we can do in our locality is the prime importance. And I'm sure the topics and the speakers will do justice to the very important discussion that will follow along with their presentation. And I wish this particular webinar a great success, as it is always, because at the end of the day, the take-home message remains in front of our eyes, in our brain, so that we put it into practice for the woman in concern, and especially in the month of March, what we call it Women's Day or Women's Week or Women's. So with these few words, I would like to thank you so much for asking me to be the guest of honor, and I wish this particular webinar a grand success.
Thank you, sir, for your words of encouragement. Now we will start with the scientific session, and I hand over the proceedings to Dr. Deepti Goswami.
Good evening and warm welcome to our chief guest, Dr. Gokuldas sir, guest of honor, Dr. Arun Madhav sir, eminent speakers, chairpersons, and all the delegates. I welcome you all for today's webinar on high-risk pregnancy on behalf of Northeast Obstetrics and Gynae Society. So without wasting much time, let us begin our scientific session. Our first session is on preeclampsia approach and challenges. May I request our first chairperson, Professor Saswati Sanil Chaudhary, to chair the session. She is a professor of Department of ONG, Guwahati Medical College. She has been the chairperson of Medical Education Committee from 2013 to 2015. She is a vice president of ISOPAP from 2020 to 2022 and president ISOPAP Assam chapter. She was a past president of Guwahati Obstetrics and Gynae Society and a member editorial board, New Indian Journal of Obs and Gynae. Ma'am, may I request to chair the session and kindly introduce our speaker, Dr. Sadhna Gupta.
Thank you, Dr. Deepti. It's my privilege to chair the session of Dr. Sadhana Gupta. Is a very good friend of mine. I don't know how long we are being friends in this Foxy. And she's can I have her this thing? Yeah. I know her personally. I know her so many things, but official, I want that official, whatever she's there. Yeah. She was a Foxy representative of SAFOX in 2018, and she was also an ICOG Governing Council member. And the most important work she has done when she was a chairperson in Foxy Safe Motherhood Committee, she has given at least 3 or 4 Foxy focus on preeclampsia, then postpartum hemorrhage, then on antepartum hemorrhage, high-risk pregnancy, and those are so good books. And she has also written a book for the undergraduates. If anybody has seen that book, it's a very good book for the undergraduates. And she has an excellent academic career, and because she got medal from SN Medical College, Agra. She was recipient of 9 gold medal in MBBS, and another gold medal for postgraduate, thrice Korean award, and thrice DC Datta Prize Award for Foxy publication. I think that academic itself tells you how good is she and how much dedicated. She has worked so much for this, for the mothers when she was the vice president as well as the chairperson of that committee. She has worked a lot on she gotten social and organizational awards. She has done so many conferences. We have been to Gorakhpur. We know how good was the conference. Saving Mothers, number of times she has done all those. And she's really, really passionate about her work. And she's a person who believes in this particular word of Gita, that is Karmanyeva Adhikaraste Ma Phaleshu Kadachana. I'm sure she's all there for all the mothers who are at risk and who needs them. And I wish her success for the coming elections. And let us hear what she's going to tell us regarding this preeclampsia, because it is being one of the important complications and problems of cause of maternal death. We know our maternal MMR is 205 in comparison to India's 103. So we are twice, so we have to keep down that. And 1/3 of these mothers die due to preeclampsia. So Sadhana, the podium is yours.
Thank you, Shashwati, for kind introduction, and my sincere regards to Dr. Gokul Das and Dr. Arun, who has been always mentor and taught so many things in Foxy journey on the subject, and my hearty gratitude to Dr. Indrani and Dr. Deepti Goswami for giving this opportunity. So let me share the screen and so as you say that Dr. Gokul Das, Dr. Arun, and Dr. Shashwati all have set the stage for all the challenges. And Dr. Indrani gave me the topic, what are the challenges and approach. And since a long journey when I was totally young in Foxy, and I listened Dr. Gokul Das, Dr. Arun with sharing their concern, and then Dr. Shashwati, and then so many, like what are the issues with us? And that is the way that we have to work together, because we have to take the specialized situation, geographical terrain, political situations, other things like social factor when we think of science and the academics. So it is the thing which we have to deal with, and great memories for being always and always there for so many conferences. And it is a real pleasant, and what we can say, it gives us, it rejuvenates us being the Northeast societies and the beautiful people. So I've been greetings, and what Shashwati was talking about, that we had a lot of publication. It was around 10 Foxy publications with me, and why we are here to save lives. And that's why it is the only reason, the same thread which join us together from the different places, and we make to learn from everybody and every situation. So many God is same, but the different are named, and so is the toxemia of the pregnancy, which we once told about it, and now it is hypertensive pregnancy disorder and the gestosis as well. So what is the magnitude? Why it is there? It is everywhere, constituting around 10 to 15% of all pregnant women, and it is a preeclampsia itself affect 3 to 5% of pregnancies, and it contribute to 10 to 15% of direct maternal death globally. Even in developed world, it is a issue for the critical morbidity and mortality, but the women in low resource countries are at higher risk of developing preeclampsia. It is in India, what is there, more than 35,000 mothers died due to HDP in 2017, and it is going to rise because more obese patient, more aged patient, and the patient with comorbidities are entering in pregnancy in India, and it is bound to get the rise. We have a lot of short-term as well as a long-term complication. Major contributor to perinatal death, perinatal morbidity, preterm birth, and a financial resource on the healthcare system and the families, because the baby many times is given the birth early by induction of labor. Then there are a critical illness immediate to mother like cerebrovascular accident, abruptio, and the long-term risk of the mother for the all metabolic disorder. And as in India, we are facing on one way anemia and the preeclampsia and eclampsia and the life thing hemorrhage, and on the other hand, we are struggling with the metabolic comorbidities even in the younger age, and the preeclampsia put a long-term risk for all metabolic disorders in the young population. So the magnitude and impact of preeclampsia is too much. When we define it, it is still like, it is always a question mark, but what is the traditionally definition? That systolic blood pressure more than 140, diastolic 90 millimeter Hg or both, but it should be in sitting or left lateral position after 20 weeks with appropriate size cup with a calibrated sphygmomanometer, at least 2 reading taken 4 apart. So it is the question and the introspective question that how carefully we take blood pressure of our pregnant women in a very busy OPD. And here we really tend to miss the diagnosis. These are the few pictures that how the blood pressure should be taken. Beside it making the things complicated for the simple diagnosis of hypertensive disorder in pregnancy, white coat hypertension, masked hypertension, delta hypertension, that is blood pressure high in the hospital, not at home. A little sudden rise, but otherwise it is normal. But any sort of hypertension can predispose to hypertensive disorder of pregnancy as well as the preeclampsia. And still we don't know that actually what is the 9-month variable for the blood pressure. So very simple thing is still a complicated issue in the implementation as well as in the observation. Early onset and the late onset preeclampsia, both are the different entity. Early onset before 34 week of gestation with a lot of fetal issue, fetal IUGR, abnormal Doppler, low birth weight and adverse maternal and neonatal outcome. But the late onset preeclampsia, which happens after 34 week, we can be a little like hopeful because they have the larger or normal placental volume. Dopplers are not that disturbed, almost birth weight is normal and has got a more favorable maternal and neonatal outcome. And why this understanding is important, because we have to differentiate very, very carefully that it is a early onset preeclampsia or the late onset preeclampsia, because the management line is different, because the prognosis is also different. So a proteinuria. So it is our classical understanding that for the diagnosis of preeclampsia, proteinuria should be there. Now the proteinuria is not considered mandatory, but I will say that for all practical understanding and the implementation, proteinuria still is an important entity because it can be done right at the point of care test. When we can have the chronic hypertension before 20 weeks of pregnancy. And another issue and the challenges is this: if the patient comes to us in the second trimester around 18 to 20 weeks, the patient blood pressure is normal and patient can be hypertensive initially, but we are missing because there is a physiological drop of blood pressure. There can be superimposed preeclampsia on the pre-existing hypertension, then eclampsia, and current definition is the hypertension with or without proteinuria with one or more system involvement and fetal growth restriction. So that makes our diagnostic issue more difficult, because we have to keep the watch on the organ dysfunction as well as the fetal growth restriction when we term the patient as a preeclampsia. So proteinuria, the issues are that it is, what is proteinuria? It is 300 milligram deciliter protein in 24 hours. Always, it is not done for the 24-hour collection, and now we are switching to protein creatinine ratio of 0.30 or more. The issue is that we can have the false positive even in the range of +3 in 7% of patients, but still, if we take the criteria of 2+ on the dipstick, it is a reasonable value for consideration and the diagnosis of the preeclampsia. So proteinuria, yes, to our setting, I think we should be very careful about it. Besides, we have to look for the other organ dysfunction, which is kidney, liver, neurological feature, hemolysis, or thrombocytopenia. So we have to see wise and act wise, because life is a consequence. Now, severe preeclampsia with severe features, and I will really like to share few very, very pertinent thoughts about it. So this is the classical table that what is non-severe and severe when we have got the more blood pressure 160/110 and organ involvement, liver, kidney, platelet, coagulation, fetal growth restriction, or the neurological thing. And it is like a fire spreading across the all organ, and we have to be ready with fire drill. But actually the issue why we are not able to deal that effectively with preeclampsia, because we don't know what is the etiology of the preeclampsia. Always a lot of etiology start from the maternal impaired trophoblastic invasion of spiral artery to endothelial dysfunction, angiogenesis abnormal, exaggerated response, then platelet activation and abnormal hemostasis, and that cause the multi-organ involvement. It is considered it is first stage on second stage, but for all practical purpose, it is a continuum process, and it is the staging is actually artificial. And preeclampsia syndrome presents clinically as a spectrum of worsening disease. So points to ponder that even a fetus is not required. Vesicular mole can have the preeclampsia. Abdominal pregnancy can have a lot of genetic issue, and the genetic susceptibility is there. Now, this is the fetal or multiple organ involvement and the coagulation disorder and the fetal involvement. What are the emerging thought? And it is very, very interesting to share that the change in vaginal microbiome, bacterial infection are supposed to be one of the triggering factor for the decidual vascular inflammation. Besides this, there can be acute arthrosis, which can result into the poor remodeling. Very, very important, this the thought process that placenta and preeclampsia, it is villain or victim. And it says that the women who develop preeclampsia have got the suboptimal cardiovascular performance, and that's why there is a uteroplacental malperfusion. And we have to check if the patient is having a subnormal capacity which a pregnancy requires, then these patients are prone to develop the preeclampsia. And that is like a 180-degree change in our understanding of etiopathogenesis of preeclampsia. So coming to this concern about etiopathogenesis and understanding that where we are, how we are really understanding preeclampsia, how we can predict and prevent. And whenever we have the webinar and conference, usually what the expert people load the person to a lot of information. And what Dr. Shashwati and Dr. Arun and everybody shared the concern that how many resources are available for us. And one message what we want to give, that maternal factors, that is maternal biophysical profile and mean arterial pressure. That is the thing which we can do for everyone, and the uterine artery Doppler, and if possible placental growth factor for high risk women. So the best screening combination, we know best risk factor, arterial pressure, PLGF, uterine artery Doppler, and if the fetal aneuploidy screen is being done, then we can look that the Papa levels are low or not. That can predict the preeclampsia. But we must know that what can be done in all settings, and that is a beautiful gestosis score developed by Dr. Sanjay Gupta, Gorak Madrukar, that this is the simple clinical score, and we take a good history like hypertension, polycystic ovaries, GDM, and a clinical feature, and we can really predict the preeclampsia and that woman to the good 60 to 70% sensitivity. So costly biomarker, I always listen PLGF, and in a very low resource states, I listen that I do SLFT for every patient, but it is to our thought process that first the clinical biophysical profile, second is the arterial blood pressure carefully taken, and then we can use the biomarker whenever they are feasible and the push woman is having a lot of high risk factor. SFNT PLGF score is important in the second trimester because it is a second trimester predicting tool, and especially not like when we have the hills and we don't know how the patient can be in hospital for so many days. So SFNT PLGF score, it is important in second trimester because if it is normal, then it is quite predictable that this woman is not going to have preeclampsia at least in the next 7 to 10 days. So the knowledge, when we implicate in the right circumstances for the right patient, then it becomes a cost-effective tool. And if we do randomly for all, then it becomes an economic burden to our healthcare system as well as the patient. So that is the all wisdom which we actually have to curtail and which we have to disseminate to our all level of obstetrician. Prevention, it is 150 milligram aspirin which has been found effective. It should be started before 16 week of pregnancy and continued up to the 36 week of pregnancy, and it should be taken at the night time. Still there is a issue of a lot of issues about what is the dose. It is 75, it is 81, how we can like have 81, then 88, then 150. But the trial was given done on the aspirin 150 milligram per day. So the recommendation is for aspirin 150 milligram per day for the prevention of preeclampsia. So finally question is, do we recommend aspirin to all? Then the answer is no, because it has got its own issue, but we should prescribe it in a high risk and the moderate risk women for the preeclampsia. Calcium supplementation, a very, very safe strategy. Our all population is calcium deficient, and around 1500 to 2000 milligram per day we give right from the second trimester, and it has got the byproduct as the prevention of the preeclampsia also. Now, this is very important that we did give a lot of effort what is severe and what is non-severe preeclampsia, whether this term is needed or not, and ISHP place a very important question mark about this severity and non-severity, and it says that declassify it, and for the reasons because we never know that today it is mild and tomorrow it is severe. So we cannot give a very relaxing attitude to message to our nurses and obstetrician that, oh, it is 140, 98, after 3 days it is 160, 110. So we should be very, very careful about it. Severe preeclampsia feature can be life-threatening complication, edema, myocardial infarction, stroke, ARDS, coagulopathy, renal failure, fetal complication like IUFD, and it is a major contributor to near miss as well as the maternal mortality. And a lot of prenatal, perinatal complication right from intrauterine to the long-term complication, and that's why preeclampsia is there. Like we have to be very, very knowledgeable, as well as in action we have to be very, very meticulous also. And this is again what we say, that because preeclampsia can deteriorate rapidly and without warning, we should not recommend it as a mild or severe. Every case of preeclampsia, if it is high blood pressure with organ involvement or with proteinuria, we should think it is a preeclampsia and taking all the precaution as it is. It cannot be diagnosed definitely. It is just because we have to have a more and more antenatal follow-up. That is the way that we have to follow these patients very, very closely. And what are the goal of management? We want to terminate pregnancy when the fetus is viable and healthy and the mother health is restored after delivery of the baby. Most of the preeclampsia, most of the situation, leave aside atypical preeclampsia, the termination of the mother is beneficial to mother, but not always for the baby. And that's why we have to confirm that the patient is having preeclampsia and how much organ involvement is there. So when we in OPD, we find it is 140/90 or 150/100, what we should do? We should first confirm the diagnosis of preeclampsia. You can hospitalize it for a day, or you can order all the investigation and make sure that the patient is compliant. Then it is a question mark that we should do it as a OPD services or indoor services. But what the observation have found, that if we do not confirm preeclampsia and its organ involvement, then the women come more often with the sign of very, very severe complication of preeclampsia. And we have to be very careful that we confirm the diagnosis as well as the organ involvement. Many times the women are so busy, they cannot afford to hospital stay. There are a lot of responsibility and we cannot pressurize them, they just we do it. And we have to take a balanced decision that we don't lose the patient of preeclampsia and we don't encounter the complication of preeclampsia, but we have the supporting care for all. So what we do for the baseline evaluation, it is daily weight, 4-hourly blood pressure, urine dipstick, protein, complete blood count, renal and liver function test, and a close follow-up. So the blood test evaluation, how frequent? This is another question. It should be done at least twice weekly. And again, if there is any change in clinical status. So all investigation twice weekly, sometimes fundoscopy is required to differentiate between chronic and new onset disease. Fetal evaluation is very, very important because fetus is at the target. So we have to be very, very sure about amniotic fluid index, umbilical artery ultrasound. And again, this is my one very important consideration, that umbilical artery Doppler is very, very simple thing to do. Every obstetrician can learn it to locate ultrasound, the umbilical artery, and do it Doppler. And it gives you then and there the way the fetus is going, and yet you can do the timely intervention. It is really difficult to go the patient from this and getting full Doppler and coming report after one day, and then the one day actually situation is going to be changed. So it is actually how we have to pull the solution. It is not that we overburden after all with all the knowledge and all the complicated study, but it is the thing that how we can train our obstetrician in the simple thing which are having the important role in the decision making, and that is the way should be. And the lot of issue that it is when the fetal IUGR is there, then you have to have a color Doppler, and a lot of issues that when there is a really fetal affected, then we have to be careful that the fetus is delivered timely. So we have to think clear and act clear. If umbilical artery flow is absent, then delivery to be taken no later than 34 weeks. If there is a reverse endostic flow, then delivery should be taken not later than the 30 weeks. And the earlier delivery is indicated in case of fetal IUGR is progressing and deterioration of sonographic variable. And this is the thing that as an obstetrician and we can do in our own machine. So we have to be very, very particular that how to recognize it. And in my practice, actually right at the midnight or early morning when we put it, and we can do real timely induction and timely delivery of the baby. So after baseline evacuation, always see very, very closely. Close visit, that is the one message, that whenever the woman is having preeclampsia, she needs very, very close visit and asking for ominous symptom, headache or visual disturbances, right upper quadrant pain, platelet count, and the renal and cardiac involvement, fetal IUGR, and the early onset disease. And more ominous symptoms are there this is less probability that patient will continue the pregnancy for longer time. It is our gestosis score, and again it shows all the obvious symptom and all the investigation. MRI for brain imaging not needed for all. Uric acid and LDH is also not recommended for all, only whenever it is needed. Again, I will say ISHP statement, and I find that why this society recommendation are important, because they are not considering the experts' opinion, which are being done in research setting. They are considering the all cadre of obstetrician, from young, from newest, from low resource setting, and that's why they say that whenever it is preeclampsia, we should give one message that it is preeclampsia and to be considered very, very seriously. We can have a full PS and mini PS, and again for low resource setting, I don't see any reason to be defensive or something inferiority about low resource setting. I see all reason to be proud that we can do best for the good economic, cost-effective investigation as well as the cost-effective intervention. It is nothing to be become defensive, and I'm really not at all it is something that developed world, developing world, low middle income, high income, because human life is one everywhere. And it is our role that what we can do best to offer to our patients. So this is all what we can do. And what is the thing that don't wait for complication? This is very, very important. Don't wait for the myocardial infarction, stroke, or HELP syndrome, or pulmonary edema, eclampsia. We have to prevent the complication so that their life is saved and our life is also saved. We are not having the dangerous game, but the safe game. About seizure prophylaxis, what is there with the preeclampsia with severe features? We know Pritchard regime, 14-gram loading dose followed by 5-gram intramuscularly 4 hourly. And again, what we say that in low resource setting, in every preeclampsia with a little bit of severe feature or organ involvement, we should give Maxelf as the seizure prophylaxis. It is not the very much severity based. It is what we know Pritchard regime, and always it is to be continued 24 hours. Still there are issues. People are afraid of the complication of Maxelf. And what is the way out? First of all, make them confident that you can monitor Maxelf with the clinical monitoring, that is respiratory rate, patellar reflex, and the urine output. Secondly, we should be confident whenever there are signs of overdose like oxygen and the calcium gluconate. Of course, sometimes there is a respiratory depression. And actually, this is the most important hesitancy that the obstetrician in low resource setting, in remote area, they don't want to give the IV dose, especially because they don't have the resource for intubation and anesthesia. And what is there, that the takeaway is that for every institution, you consider your resource, your backup, but give Maxelf, you can give only intramuscular and shift the patient to the referral center. You can, but there must be some policy that the Maxelf is being given. Second is the antihypertensive regime. When we want parenteral antihypertensive, when there is a blood pressure more than 160 by 110. What we want to have achieved by the antihypertensive, we want to achieve only 15 to 25% reduction. And what drugs we want to have? Who have the rapid onset of action and the short duration of action. So in case there is a sudden drop of blood pressure, we don't put into the hypotensive crisis. So this is the goal of the antihypertensive. We don't want to have all hypertensive complications, especially cardiovascular, and antihypertensive agent should be administered when you have confirmed that the patient is having the severe hypertension and it is persistent on the 2 reading. What are the target level? To gestosis, our Indian chapter says it is 140 by 90. Lobetalol, hydrolagine, and nifedipine, which we are giving as an obstetrician, and nitroprusside and nitroglycerin, which should be given under the ICU or the physician care. And it is all, we know the dosage, it is 20 and the maximum is 280 with the lobetalol. And this is the thing which we have to know. But one message I want to give, if the patient is having tachycardia, then don't give nifedipine, give lobetalol. If the patient is having bradycardia, then nifedipine can be a better choice. Hydrogen is not available in many settings. So lobetalol and nifedipine is our like main crux of treatment for the severe hypertension, and we have to make the choices out of it, but we should know how optimally we can give. So a 200 watt, if the one drug is not getting to achieve desired hypertension, then add the another drug. So don't stick to the one drug with the highest dose, that is lobetalol 2400 milligram, but it is better that we add the nifedipine so that we get the benefit of both. What antihypertensive not to be given? That is ACE inhibitor, angiotensin receptor blocker, diuretic, beta blocker, and the calcium channel antagonist, except nifedipine. So this is very important, that what antihypertensive not to be given, because patient many times the physician write the losartan and the diuretics, and that has to be avoided. In next 7 or 8 minutes, I will go for the eclampsia, that is the complication. And in tertiary care, the patient are having, the facilities are having a lot of eclampsia. Fortunately, in private setting, it is on the less, because we are diagnosing better and we are treating better. And whenever there is eclampsia, it is a life-threatening emergency, airway, breathing. If oxygen saturation is less than 92%, consider that the patient has aspirated or there is pulmonary edema. So it is very important, and that patient require the arterial blood gas analysis and other treatment. Circulation, crystalloid vary 65 to 80 ml per hour, and the fall is catheterization. So when the patient with eclampsia come to you, prevent hypoxia by ABC, prevent maternal injury and aspiration. Do not go after the first season. Prevent, give supportive care, and then you do the Maxulp and the antihypertensive therapy. It is the same dose of the Maxulp, and we should be composed, and we should be like careful that we have all the supportive care. If recurrent eclampsia, next 2 to 4 gram of Maxulp. In resistant eclampsia or the conversion, then thiopental or phenytoin can be used again with the intensivist presence and the ICU care. It is important, if the patient is not responding to Maxulp and your anticonvulsant, then there can be some cerebrovascular accident and incident, and these patients require head imaging. So you have to be very careful about the stabilization of eclamptic women. Fetal heart can be bradycardia, grossly hypoxic. Don't go. This is the common thing whenever we take panel. Especially the young ones, we will take the patient to OT for cesarean section. So don't do cesarean in unstabilized patient. Don't do cesarean during scissor. We will have a lot of fetal CTG non-reassuring, and you stabilize the patient and it comes normal. So it is really critical that we don't do cesarean section or take decision because of the non-reassuring fetal CTG. So it is very important. That's why obstetrical decision makes our destiny. Health syndrome, I will go very quickly. It is class 1, 2, 3, partial and full health. And the management is the same: Maxulp, antihypertensive, and timely termination. And why I am going very quickly, because again ISHP says that the health is the synonym of the one of the presentation of the preeclampsia, and it does not require actually the different source of management and different approach. But just we have to be careful that these patients require, especially in a full-fledged health, the early termination. And what is ISHP does not consider now help as a different presentation of preeclampsia. Always be careful. Aspirin we are giving as a prophylaxis, and many people are giving heparin also, though it is not a preventive drug. But these drugs can cause the neurological hemorrhage, and you should be very careful about the cerebrovascular complication. Subcapsular liver hematoma, very critical situation, require multidisciplinary team. What is the message? Just ask for the epigastric pain, any unexplained malaise, any unexplained nausea and vomiting, any unexplained respiratory difficulty. You think of all these complications, and when you diagnose it well, then it requires really massive blood transfusion and multidisciplinary team. Transfer protocol is very important, and when you transfer the patient, always give first dose of Maxulp. No sublingual nifedipine. Try to give first dose of antihypertensive, give one supporting care, and just be very, very careful that there is somebody to take care when if the patient convulses or any complication happens in the way. And that is very, very important in the, especially in the hilly terrain. In the ER also we have a Uttarakhand and a lot of difficult issue, and we have to be care that we are not pushing them out of our hospital, but we are transferring to a good referral center with all the prior information. A little bit about the termination. Again, I have said that absent flow, then it is 34 week, reverse flow, it is around 30 week. And we have to consider if the normal, no severe feature or patient is not deteriorating, fetus is not deteriorating, then consider that termination should be around 37 week. So we have to see follow platelet count, liver function, renal function, neurological feature, fetal growth. And when you see that there is a deterioration, now this is the time to terminate. So this is the fetal concern, always a steroid priming, and if the fetus is premature, Maxel really we are giving, and that is add on to the neurological protection also. Always consider these deliveries in a very, very well equipped center. Cesarean, again, now we a low, very, very low threshold of obstetrician for cesarean, but we can avoid cesarean section in around 40 to 50% case, and cesarean is preferred when there is a severe FGR, reverse and diastolic flow, CPD, major obstetrical indication, and the severe oligohydramnios, and very, very preterm babies. So we must have the clear indication of cesarean section. In preeclampsia, it is no way that every patient who is having preeclampsia or any complication we put on the cesarean section, because it is also coming back to our all obstetrical morbidity. And always give oral antihypertensive, treat, keep the patient blood pressure in the control, and all the fluid balance, that is 60 to 80 ml per hour. Don't fluid give overfluid, that the patient is very, very prone to develop pulmonary edema. Anesthetic consideration, again, spinal anesthesia and the epidural anesthesia is the anesthesia of choice unless there is a thrombocytopenia. So keep very, very sure that the general anesthesia has a more risk for the pregnant woman, also in the preeclampsia, not only in every patient. So it is very important. Secondly, this anesthetic complication can be very, very critical for preeclamptic patient. Always tell anesthetist if you have given Maxel for seizure prophylaxis, because it causes the respiratory depression and it can cause problem for the anesthetist and the coming out of the anesthesia. Besides this, nifedipine and the Maxel, both are causing uterine relaxation. A prompt AMTSL, that is important. Now we have a carbetocin, a wonder drug for the prevention of PPH, and this combination of preeclampsia and PPH is something, a monstrous combination. So we cannot over infuse the fluid, like 3 or 4 liters of fluid. We have to restrict the fluid, and the patient does not tolerate PPH. So preventive measures are must, and when the patient have the PPH, we have to be ready with the blood product, that is the plasma, and the PRBC. That is important thing, and the important readiness whenever we are having the cesarean or vaginal delivery for these patients. And always I say 100% AMTSL, and carbetocin is, I think it is one of the very, very good drug which has come to our rescue. Better always send histopathological examination of placenta after delivery. In postpartum period, be very, very careful. Patient can have fit, patient can have pulmonary edema, patient can have respiratory, neurological complication. You should be, nurses should be very, very careful, our resident, that this is preeclampsia. Don't shift them from the HDU to the ward, and the suddenly the patient come with the hypertensive crisis. Be greatly vigilant, really. In like I have seen 4 or 5 in my patient on 24, after 24 or 36 hours, patient suddenly develop flash pulmonary edema, suddenly develop severe hypertension. And this is the, like, for 36 to 48 hours, you should be very, very meticulous for measuring blood pressure, oxygen saturation, behavior, and the consciousness level. Don't discharge these patients early, at least after 5 days. see the patient, don't taper the blood pressure antihypertensive drug immediately, because after 2 days she will again have the high blood pressure. So we taper them slowly with a close watch. Better to avoid NSID and always have a good short-term follow-up. Call them after 7 days that the blood pressure are normal or lab investigation are normal, and they should be reviewed that they are different, and don't compare with the other normal patient. They must have a very good 7 month and 1 month and 3 month postpartum visit period. Ask these patients, don't lose them in the world. They are more prone to have the preeclampsia, small gestational age, next pregnancy. They are more prone to develop hypertension and diabetes mellitus and metabolic disorder. Ask them always, you check your blood pressure, check your other thing, keep the like something on the diet and the exercise so that they don't suffer. This is the positive intervention which as a obstetrician and gynecologist we can do. Our major intervention in prevention of the metabolic disorders and the morbidities, as well as the next pregnancy complication. So life is full cycle, and pregnancy test women health status at many fronts. We as obstetricians are really fortunate and blessed to intervene lifestyle and medical intervention at young age, and what decision and what time and what implication we do in our clinic have a short and long term of health of not only mother but the generation next. So thanks again for always being together. It is always the being to the all Gangtok, Shillong, Guwahati has been some of the most beautiful memories with the most wonderful people, most wonderful colleague, and we hope that we will stay together for a long time. And with this, when the election is on, I seek everybody's full-hearted support to honor the value of commitment, conviction, compassion, and dedication, democracy, and difference. Thank you very much.
Thank you, Sadhna. It's an exhaustive lecture. I think you have not a single stone unturned. All the new things you have, everything has been included, starting from PLGF, starting from MAP, starting from ultranarity Doppler, and starting from declassification, such an important thing that you should not think that this is not going to have preeclampsia. This is, I always tell my students, it may be a spectrum of a single disease which starts with a mild hypertension, and over a period of time it may become to severe eclampsia if you do not follow that particular, and you have not lived anything like management and then post-operative management. It's so important. A simple, I think that oxygen saturation, you can abort an attack of pulmonary edema. That is so important. Small things.
Disha.
Okay. I think we can go forward.
Thank you, ma'am, Sadhna Gupta, ma'am, for your such an elaborate and wonderful presentation. We really thank you, and thanks to our chairperson who is always with us, Dr. Sashwati, ma'am. Thank you so much. Let us move on to our second topic. The second topic is on induction of labor in high-risk cases, the evidence-based guidelines. May I request our chairperson for this session, Dr. Nilakhi Fukunkumar. She is a consultant, senior consultant at the Downtown Hospital and also at Dr. K.C. Das Nursing Home, Guwahati. She is a visiting consultant at Pratiksha Hospital, Guwahati. She is a director at Gynec Center, and at present she is a president of Guwahati Obstetrics and Gynae Society. She is a former secretary of IMS Guwahati chapter. She is a founder president of Guwahati Menopause Society. She is a joint secretary of AICOG Guwahati. She has been invited faculty in many national conferences, and she's worked with ASMIN. She's working with ASMIN NGO on cancer awareness in women of Northeast region. May I request Dr. Nilakhi Baido to kindly introduce our speaker, Dr. Qureshi Sharma, for this session.
Thank you, Deepti. It is my pleasure to be a part of this well-organized very important subject at CME. Deepti Gupta, please show Purosri's CV. So I welcome Dr. Purosri Sharma, who is an assistant professor in Guwahati Medical College and a very learned obstetrician. And she is supposed to talk on induction of labor in high-risk cases. And let us learn from her what the evidence is. It is very, as we know, it is very important subject, when and how to induce labor to get a healthy baby and as well as to save the life of the mother. Dr. Purosri, please, you can start your deliberation.
Good evening, everyone. Very warm welcome. I feel very privileged to have been chosen as a speaker for this evening. And my topic is induction of labor in high-risk pregnancy. Now, as Arun Madhav Borua sir has already said that there is no low-risk pregnancy. So all the pregnancies are high-risk pregnancies. But I had to pick up a few topics from the list of medical conditions complicating pregnancy, just to describe them as a high-risk pregnancy. Now, a few lines about the history about the induction of labor. So, history of induction goes back to the days of Hippocrates, and initially the induction of labor came to the mind of the people only for the cases of intrauterine demise cases where the fetus was dead, and that caused a lot of psychological distress to the patient, and that's how the idea of induction of labor came into existence. So initially amniotomy was done, and even before that, the most common other ways of inducing labor was like walking, like vaginal intercourse, participating in heavy exercise, spicy foods, herbal tea, and even nipple stimulation. Now, mechanical manipulations are also tried, like digital stretching, repeated pressurized douches, stents, buoys, catheters, and later castor oil, quinine, the antimalarials, or even posterior pituitary extracts are also used for induction of labor. Now, the bogies were introduced in 1855, then rupture of the forewater came into existence in 1756. Then Drew Smith introduced the idea of rupture of hindwater for induction of labor in 1931. Then 1952, oxytocin was first used, which was a posterior pituitary extract for induction of labor. Then came the prostaglandins in 1930, and which is a big event in the induction of labor, where now different modifications of different generations of prostaglandins we are using now. Now, the pharmacological synthesis of prostaglandins are followed by its application in the clinical practice has made a big breakthrough. Next slide. Next slide. For induction of labor, the cases has to be selected, and once the cases are selected, all the cases needing induction needs admission. The procedure has to be explained to the party, discussed with the party, and the indications for inductions are many, but the outcome is always unpredictable. We do not know which are the cases going to deliver vaginally and which are the cases not going to progress and also see the progress of labor. So for this, we need a scoring system, which is called a modified Bishop score. Therefore, all of us were already following this score. We all know the scoring system, but the modification was done in 1982, and the modification was that a cervical length was taken in place of effacement. So even a TVS can be done to assess the length of the cervix. So cervical length was the only modification, and there was subtraction of -1 and addition of +2 points in the modified score. +1 point was added for all cases of preeclampsia and each prior vaginal delivery cases. And 1 point was subtracted for cases having PPROM, nulliparity, and multiparous. So in 2011, the World Health Organization published the recommendations for induction of labor, and which has not been amended till now. So induction of labor should be performed only when there is a clear medical indication for it, and expected benefits should outweigh the potential harms. Consideration must be given to the actual condition, wishes, and preferences of each woman, with emphasis being placed on the cervical status, specific method of induction of labor, and associated conditions such as parity and rupture of membrane. Induction should be performed with caution since the procedure carries the risk of uterine hyperstimulation, rupture, fetal distress, etc. Now, whenever induction of labor is carried out, facilities should be available for assessing maternal and fetal well-being. Then, patients receiving oxytocin, misoprostol, or any prostaglandin should never be left unattended. And failed induction does not necessarily indicate a cesarean. Once the induction has failed, then we should reassess the case and discuss the situation with the party. Maybe we can go for reinduction with a different method after giving her rest for some time, which really works in some cases. We have seen it. So failed induction does not necessarily mean that we should jump to a operative interference. And next is, whenever possible, induction of labor should be carried out in facilities where cesarean section can be performed. So specific situations for induction of labor: so advancing maternal age, pregnancies after artificial reproductive techniques, and maternal requests. Now, all these three are special conditions where induction of labor is as such not indicated if there are no other medical indications for it or any other obstetrical indications. But there are no specific guidelines for inducing labor only for maternal requests where there are no compelling reason to induce the labor otherwise, or in pregnancies who have conceived after artificial reproductive techniques, or even the maternal age. So in this case, we do not have a clear-cut guideline, so individualization of the situation may be a norm. Now the indications, and these indications as per the SCOG guidelines. So these indications were like maternal indications, fetal indications. So maternal, you all know that postnatal pregnancy, antepartum hemorrhages where abruptio placenta has to be included, and maternal conditions like diabetes mellitus, gestational hypertension, renal disease, and heart disease. Chorioamnionitis, that it's a very big indication for inducing labor, and premature rupture of membrane. Induction of labor is approximately 12 hours, and after pre-labor rupture of membranes. Till this steroid dose is completed. The fetal indications, number one is severe IUGL, intrauterine fetal demise. In the event of an intrauterine fetal demise, there is evidence of rupture membrane infection or bleeding, immediate induction of labor is preferred management. In RH-IC immunization and even with fetal anomalies which are not compatible with extrauterine life. The elective indication, as I already said, there is no definite guideline. Now, induction of labor in the absence of acceptable maternal and fetal indications. In such cases, at least one gestational age criteria has to be fulfilled, and these guidelines I have taken from RCOG. They have said that elective induction can be done where the fetal gestational age and non-maturity has to be established by following one of these three criteria. And number one, they have said, is the ultrasound measurement of at lesser than 20 weeks of gestation, which supports the gestational age is more than 39 weeks. Or fetal heart tone has been documented as present for 30 weeks using Doppler ultrasonography. Or it has been 36 weeks since a positive serum or urine chorionic gonadotrophin beta test. So one of these criteria, if it is fulfilled and it shows that the pregnancy has been carried beyond 39 weeks, then elective induction can be taken up according to RCOG guidelines. Now, contraindications of induction, we all know there are absolute contraindications like CPDs, when the lie is not longitudinal and the tumor is there in the pelvis. Then also it is contraindicated in placenta previa, vasa previa, cord presentation, cord prolapse, invasive carcinoma cervix, and active genital herpes. Then twice post-cesarean section or classical cesarean section, inverted T-tapered incision, or previous rupture of uterus, or there is instances of full thickness myomectomy. Then unification surgery of uterine diadal fist, pelvic structural abnormalities, and also high repair of post repair of psychovaginal fistulas. Relative contraindications are maternal heart diseases like Marfan syndrome, severe pulmonary arterial hypertension, and also in breech presentation is a relative contraindications. Previous myomectomy where full thickness of the uterine wall was not attended. Then history of prior difficult or traumatic delivery. In these cases, the stress and psychologically the mother may not be prepared for taking up induction. So that is a relative contraindication for induction of labor. The methods of induction, we all know mechanical, surgical, and medical methods. Mechanical is Foley's catheter or hygroscopic dilators. Then these are best suited for post-CS cases where only for ripening of the cervix. Mechanical methods are basically for only ripening the cervix. And surgical methods are like membrane stripping and amniotomy. Next is pharmacological. Two groups of most important drugs are, one is the prostaglandin and next is oxytocin. The prostaglandin, its main role is cervical ripening by increasing the inflammatory mediator in cervix, cervical extracellular matrix, and remodeling through a decrease in collagen rings. Prostaglandin E2, dinoprostone gel we are using, then primarily cervical ripening is the, and it often initiates labor by stimulating uterine contractions. Various trials and meta-analysis have shown an increased chance of vaginal delivery within 24 hours of prostaglandin E2 when compared to a placebo or oxytocin alone. Now, prostaglandin E2 exerts its effects by alteration in the extracellular ground surface and smooth muscle activity. Now, prostaglandin E1, that is presently we are using misoprostol. It is a synthetic analog of prostaglandin E1, and it is a potent uterotonic drug. So it is the agent for induction of labor, and various trials and meta-analysis have concluded that vaginal misoprostol has reduced the rate of failure to delivery within 24 hours when compared to placebo, vaginal and intracervical prostaglandin E2 or oxytocin. So these drugs are quite effective, but misoprostol and prostaglandin are contraindicated in cases of post-CS pregnancies. Oral misoprostol has been shown to reduce cesarean section rate compared to vaginal prostaglandin E2 and placebo. However, there are slightly increased rates of uterine tachysystole and meconium-stain liquor with misoprostol, more with vaginal compared to oral route. So SUG and WHO have recommended its use as an induction agent. Adverse effects of prostaglandins are, one is uterine tachysystole, next is fetal distress, next is uterine rupture, mostly in scarred uterus and grand multipara. There may be GI symptoms like nausea, vomiting, and abdominal cramps, and chills and shivering, specifically with prostaglandin E1. So the labor has to be monitored, the induction has to be monitored. Next pharmacologic agent is oxytocin. It is an octapeptide produced by the hypothalamus and secreted by posterior pituitary. And it directly stimulates uterine contractions, and also there is increase in residual prostaglandin production. It is administered as a dilute solution by continuous intravenous infusion. Now, its side effects are uterine tachysystole with or without fatty heart rate changes, rupture, hypotension, and water intoxication. Now, since it is secreted by posterior pituitary, it has got some antidiuretic action, so their patient may go into hypotension and there may be water intoxication because it has to be given with saline or RL. Mifepristone, it is also an antiprogesterone that antagonizes the effect of progesterone, which is known to inhibit uterine contractions throughout pregnancy. But according to systemic review, mifepristone was effective in achieving cervical ripening within 48 to 72 hours and reducing the rate of cesarean sections. And next is nitric oxide donors. Then this is also under trial and is likely a mediator of cervical ripening. Two nitric oxide donors, one is isosorbide mononitrate and glyceryl trinitrate, have been studied in this context. However, more data is required before they can be taken up for induction in routine purpose. So mifepristone and nitric oxide donors are upcoming drugs. There are meta-analysis going on these drugs. The induction in high-risk pregnancy. So induction of labor has always become an important part of obstetric practice, and with safer and better agents available, induction of labor can be offered in specific situations. So I have picked up 10 situations as high-risk pregnancy cases for this presentation. So all cases needing induction have to be admitted. There have to have good facilities for cesarean section and multidisciplinary approach, and all induction cases has to be monitored properly. There should be good monitoring system, otherwise we should not go for induction of labor. The previous cesarean section, a common reason for a pre-section is a previous cesarean section. Now we can avoid this by going for feedback. So for any woman being in trial of labor after cesarean section, it is imperative that she must be counseled first appropriately and made aware of the possible adverse effects. of having repeated cesarean section. So this should be counseled. Now, numerous trials conducted so far have found that the rate of uterine rupture was least in spontaneous labor and slightly higher in women with where the labor was induced or even augmented. But again, this can be prevented just by monitoring the patient when she is receiving the induction and when she is progressing labor. A secondary observation from this study showed that uterine rupture was more likely to occur when labor was induced with an unfavorable cervix and then with a favorable cervix. So there comes the importance of having the modified Bishop's rule. And thirdly, mechanical methods by far are the safest methods for induction of labor, like intracervical catheter or hydroscopic dilutors, as they have the least rate of uterine rupture because they do not stimulate the uterus as such, they just try to soften and efface the cervix. So risk factors for complications of women undergoing induction for a previous section. So number one unfavorable factor is unfavorable cervix. Then the scar, integrity of the scar has to be known. Then malpresentation, malposition, or relatively large baby or floating head at the time of induction. These usually are not factors which gives us a good platform for induction in a post-years pregnancy. Now, absolute contraindications for induction is a cesarean section cases. These are all know already, like vasa previa, transverse layer footling, previous classical CS or rupture, even twice post CS, active herpes, invasive cervical carcinoma. Relative contraindications include previous other uterine surgery along with cesarean section, large baby, high head, and multiple pregnancy in a case of post-CS pregnancy. Now, next is gestational diabetes mellitus. This is another complications, another condition which complicates pregnancy. In pregnancies complicated by GDM, frequently the obstetrician would want to deliver the baby before the onset of spontaneous labor because there is a high risk of prenatal mortality and morbidity, and in incidences of IUDs and stillbirth. So, once the baby is mature, we would like to deliver the baby. Now, NICE guidelines say that delivery should be offered at 38 weeks. Now, according to FOXY guidelines, which came that they say that in cases of GDM cases who are maintaining well on diet, they can be carried till 39 weeks of pregnancy. And in cases where the pregnancy is diabetic or glycemic status is being maintained on oral hypoglycemic agents or insulin, they should be terminated at 38 weeks. On diet should be on up to 39 weeks, and on oral hypoglycemics and insulin, they should be terminated at 38 weeks plus. And on those cases where the glycemic status is not controlled or very unpredictable, then they have to be individualized in consultation with endocrinologist, and they may have to be terminated before even 36 weeks of pregnancy, just to avoid the perinatal mortality and morbidity. Now, most guidelines agree that delivery should be done between 38 to 39 weeks. Now, gestational hypertension, there is elevated pressure with minimal significance to severe and multi-organ dysfunction. So, this is a big spectrum of this disease, and this is the measure of the maternal and prenatal morbidity. The definitive treatment is always the birth of the fetus and the expulsion of the placenta, where induction of labor becomes a viable option. And it is a very useful method in these cases in gestational hypertension if we could deliver the baby by vaginally rather than going for a cesarean section. So just divide the cases into two groups. Where the cervix is not right, then we have to go for prostaglandins, and where the cervix is right, then we can use oxytocin and also amniotomy. The fetal growth restriction is usually defined it as a fetus with an estimated weight of less than 10th percentile for gestational age. The umbilical artery doctor is the primary surveillance tool. Now, in these cases, the late onset FGR, where more than 32 weeks, where a Doppler is normal, labor induction and delivery is recommended at 37 completed weeks, according to RCOG. However, with abnormal Doppler studies, induction has to be individualized. In these cases, the steroid dose has to be completed before going for induction of labor after counseling with the party. Now, according to RCOG, if umbilical artery or middle cerebral artery Doppler is abnormal, delivery should be recommended no later than 37 weeks. In preterm fetal growth restriction at less than 32 weeks, with absent or reversed end diastolic artery flow, the induction of labor is not recommended. Instead, a cesarean section is to be done at 30 to 34 weeks of pregnancy. So in preterm FGR, there is no risk of induction of labor, but for neuroprotection, we can give magnesium sulfate and also steroids before going for a section. The fetal macrosomia, now it is defined as a birth weight of more than 4 kg or greater than 90% for that gestational age. The delivery of a macrosomia baby is of concern as it may complicate vaginal delivery and put the baby at risk of birth trauma. Now, in these cases, there is a guideline that says that macrosomic babies where the mothers are not diabetic, they are more fit for induction of labor because there are lesser chances of shoulder dystocia compared to mothers, diabetic mothers. So SUG, RCUG, and SUGC and WHO do not support induction of labor in women without diabetes and with fetal macrosomia. In twin gestation, induction of labor is recommended at 38 weeks in dichorionic and monochorionic twins. So induction of labor and vaginal delivery is normally considered when the first twin is in cephalic presentation. In dichorionic diamniotic twins, except in cases of fetal growth restriction of one twin or a coexisting abnormality exists, where extensive antenatal testing and earlier delivery is done. In monochorionic twins, without any complication, elective induction and delivery at 36 weeks is recommended in monochorionic twins. But in twin pregnancy, delivery is not, induction is contraindicated where the first baby is non-cephalic or where there is monochorionic monoamniotic twins. In intrauterine fetal death, the decision for induction of labor is the major question, and although 80 to 90% of the patients have spontaneous labor within 2 weeks of fetal death, this expected management not only causes psychological distress to the mother but also raises the clinical concern of development of DIC, infection, septicemia, and even maternal mortality. So surgical methods are contraindicated due to high risk of infections. Ideal drug for termination in IUD cases should be effective and safe, effective, and affordable. And usually it is oxytocin. It recommends a combination of mifepristone and prostaglandin preparation as the first line for induction of labor. And once the cervix is right, then we can give oxytocin after around 6 hours. Recommended the choice of vaginal and prostaglandins, and those should be adjusted. And IUD with previous LSCS, the RCOC recommends mifepristone can be used to induce labor. Prostaglandins should be used with caution as there can be increased risk of uterine rupture. In postserious cases, there is no use of prostaglandins for induction of labor. IUD in women with 2 previous LSCs should be advised that in general, the absolute risk of induction of labor with prostaglandin is only a little higher than for women with a single previous section. Women with more than 2 LSCs or atypical scars should be advised that the safety of induction of labor is not known. And next is premature pre-labor rupture of membranes. It is defined as rupture of membranes prior to the onset of labor at or beyond 37 weeks of gestation. The current NICE guidelines and Cochrane review recommend that induction of labor approximately 24 hours after PRM is the most practicable approach. RCOC recommends that immediate induction for women colonized with group B streptococcus who experience spontaneous rupture of membranes at term to reduce the risk of early onset neonatal GBS disease. Oxytocin, prostaglandins are preferred agents for this induction of labor. In postnatal pregnancy, which is maybe the commonest indication in Asian countries, the SUG recommends definitive induction of labor after 42 weeks of gestation or between 41 to 42 weeks gestation, it can be considered. In postpartum, different methods can be used for induction of labor, but best is always membrane stripping and then oxytocin is the choice because in the absence of any other obstetric complications of pregnancy. Vaginal prostaglandin E2 and misoprostol are also effective for an unfavorable cervix. But usually stripping is enough in postpartum pregnancy or postpartum pregnancy. Now, last is the polyhydramnios. Induction may be offered in persistent idiopathic polyhydramnios once the fetus reaches 40 weeks of gestation. Several large observational studies have shown an association between idiopathic polyhydramnios and 2 to 5-fold increase in stillbirth. Hence, the induction of labor at term may be considered. So, once the baby is mature, in cases of polyhydramnios, labor has to be induced. Now, monitoring of induction of labor. Now, whenever labor is carried out, induction of labor is carried out, facility should be available for continuous electronic fetal heart rate monitoring, preferably, and if not there, then a feature has to be assessed clinically every 15 minutes in the first stage of labor and every 5 minutes in second stage of labor also. The parameters need to be monitored using a partograph in active phase of labor, where maternal pulse and BP has to be recorded. Temperature, contraction of the uterus, progress of labor, color of liquor, feature, and urine output. These are the parameters we look for in a parameter partograph. Now, this failed induction, there is no single definition to label induction as a failed induction. Failure of induction is, there are different researchers, they have come up with different definitions. So, one, they have said that inability to achieve cervical dilatation of more than 4 centimeters up to 12 plus minus 3 hours, that is 9 to 15 hours of oxytocin administration. Other definitions, they have said that failed vaginal delivery, failed entry into the active phase of labor, or even failed labor after a certain number of ripening agents. So maybe induction after 24 hours. So currently there are no criteria for failed inductions. Normally, cervical ripening itself can take some time, and the establishment of active labor is important to label labor as a failed induction. So normally what we do is, if she does not go into active phase of labor after giving a definitive dose of cervical ripening agents, or after doing amniotomy followed by oxytocin, then we label it as a failed induction. Definitions offered by other groups also vary, and they say that they may be to generate regular contractions approximately every 3 minutes, or cervical changes after at least 24 hours of oxytocin, or membrane should be artificially ruptured if safe and feasible. After ARM, one may consider a failed induction of labor if regular contractions and cervical changes do not occur after at least 10 to 12 hours of oxytocin administration. So there are some risk factors for failed induction. One is the cervical status. So unripe cervix, that is lesser than 6 some modified Bishop's score influence the labor outcomes. Now some demographic factors are there. Failed induction is 4 to 6 times more likely in nulliparous women compared to multiparous counterparts. Their maternal is more than 30 years and greater risk of having a failed induction. Gestational age with greater than 41 weeks are more likely to have a failed induction. And last and most important is obesity. Patients with higher BMI associated with higher fetal weight and pregnancy-related complications, and both these are associated with an increased risk of cesarean infection and failed induction. So fetal-maternal factors, some other factors have been statistically significant, which are associated with failed induction. So one is bad obstetric history, macrosonic babies, premature aperture of membranes, post-term pregnancy, preeclampsia, isolated oligohydramnios in the absence of any contributing factors, gestational diabetes, and Rh negative pregnancy with IUDR, they are more likely to have failed induction. The failed induction management, the case has to be discussed with the party. We have to reassess the condition. Then after monitoring, either we can go for subsequent induction with a different method, or we may have to go for a cesarean section. Thank you very much.
Thank you, Puroshree. It was a very elaborate talk. Deepti, can you have 2 or 3 questions if time permits? Deepti?
I think we can take the questions later on because we have a panel discussion also with us. So we'll take the questions, or somebody, if I want to ask question, they can write it in the chat box. We may take the questions later after the panel discussion. So I think we can go ahead with the panel discussion. Thank you, Dr. Puroshree, for your elaborate talk on the induction of labor, and especially highlighting those specialized cases. And thank you, Dr. Nilakhi Phupon Baido, for chairing the session. Now we move on to the star attraction of today's webinar, that is the panel discussion. And this is based on the case-based scenarios in the most common obstetric complication, that is postpartum hemorrhage. We have for today's this panel discussion would be moderated by Dr. Tanma Soikia Das, and we have expert panelists with us. So Dr. Tanma, she'll be moderating the session. She is the Assistant Professor of Guwahati Medical College, over 10 years experience in the subject. She's been extensively trained in high-risk obstetrics and has dealt with thousands of challenging obstetric cases with confidence and had successful outcomes. She can perform minimal access surgeries apart from conventional and gynecology, and she had been working as a gynecologist at Apollo Clinic for several years. She's been speaker at numerous conferences, and she has delivered health talks at various awareness programs. And she has also been a guest speaker at public meetings organized by Charitable Foundation. She has chaired sessions as a panelist on topics related to recent advances in the field. So, moving on to our panelists, may I welcome Dr. Alok Dev. He is a Vice President of Shillong Obstetrics and Gynae Society. Is a consultant gynecologist at the Woodland Hospital. I welcome Dr. Alok Dev. Then we have Dr. Nilotparna Saikia. She is the executive member of Shillong Obstetrics and Gynae Society. I welcome Dr. Nilotparna Saikia. Then we have our panelist, Dr. Pranabika Mohanta. She is an assistant professor at Jorhat Medical College. She is a deputy superintendent of Jorhat Medical College, and also she is a secretary, Jorhat Obstetrics and Gynae Society. Dr. Nitumoni Gogoi, she's a senior consultant at Mayflower Hospital. Then we have our next panelist is Dr. Swagata Baishya. She is a consultant at Nolbari Maternity Hospital at Sathi Multispecialty Hospital. For the past 10 years, she has worked as a gynecologist and obstetrician and gained proficient skills and knowledge in this segment. She has pursued degree of MBBS in MS gender surgery.
Sorry, I don't know.
Yeah, she's pursued.
Actually.
Yeah, we can. Okay. Then we have our panelist, Dr. Rita Nath. She has done her MBBS from Assam Medical College, Dibrugarh in 2005. She's done DTO in from Assam Medical College in 2011. She's a consultant obstetrician and gynecologist and a laparoscopic surgeon at HM Hospital. And then she is an assistant general secretary of Dibrugarh ONG Society. Next, please. And then we have Dr. Hiren Kumar Das. He's a senior medical and health officer of Team FRU Nogao, and he works at the Health and Family Welfare Department, Government of Assam. So I welcome all the panelists for this panel-based discussion on PPH. And may I request Dr. Tanma to kindly moderate the session. Tanma?
Yes, just coming on. Are my slides visible?
Ma'am, not in chat, ma'am. Can you please share, ma'am?
Am I visible now?
Yes, ma'am. Yes, ma'am. The slides are synced. Can you please go to the slideshow mode, ma'am?
Yes. Good evening, Dr. Gokuldas.
Sorry to interrupt, ma'am. The slideshow mode is not visible. Can you please stop share and share again, ma'am?
Okay. Yes. Is it visible now?
Yes, ma'am. Yes, ma'am. Perfect, ma'am. Thank you, ma'am.
Good evening, Dr. Gokuldas, sir, Dr. Arun Madhav, sir, Sadhna Gupta, ma'am, all my seniors and all delegates present today. Thank you for this opportunity to moderate this important session on PPH. The panelists are from different parts of Assam and Shillong, and they're all experienced gynecologists. So I'm looking forward to a lot of inputs from them, valuable inputs rather. So coming to the okay. So 5% of all women giving birth around the world, they have PPH, and globally nearly 1/4 of them, maternal deaths, are because of PPH. In most low-income countries, this is the main cause of mortality. And the latest third sustainable development goal that we have, SDG 3, is 70-30. That means we want to reduce the global maternal mortality ratio to less than 70 per 1 lakh live births by 2030. And to do this, we all need to practice evidence-based medicine and management of PPH. And so moving on to the first case, as we're short of time, Mrs. X, 26 years, primigravida,
at 37 weeks of gestation with PIH, BP 150 by 100, with moderate anemia, hemoglobin 9 gram percent, underwent induction of labor for PIH with cerviprime gel and was followed by augmentation with oxytocin. Patient had fetal distress in the second stage and was delivered with forceps application following RMLE. My first question is to Dr. Rita. Could you tell us what are the risk factors for PPH in this case?
Hello, a very good evening to my respected teachers and delegates from Assam and Shillong. And the main risk factor here, the most common risk factor will be the PIH itself. And she is also having moderate anemia.
Right.
So these two are the main cases here. And after taking the detailed history of the patient, we'll come to know the other risk factors, like if she belongs to a low socioeconomic status, if there are some pre-existing infections, like before that, or she had any premature rupture of membrane. All those will be the risk factor associated with it. But the foremost thing, the risk factor is the PIH.
Okay.
PIH as
So
well as the anemia.
these are the risk factors: anemia, PIH. There was augmentation of labor with oxytocin and forceps delivery.
Yes, ma'am.
Instrumental delivery is also a high risk factor for traumatic PPH.
Yes, ma'am.
Yes. So next question, the patient after delivery of the baby was followed by profuse bleeding. Active management of third stage labor was done and placenta was delivered within 5 minutes. There was a puddle of blood on the bed and soon it started dripping on the floor. The patient turned pale, her pulse was 120 per minute, low volume, and BP was 80 by 50. So my next question is, when would you call it PPH in a case of bleeding? Dr. Swagata, would you like to take this?
Yes, ma'am. First of all, thank you for including me as a panelist today. And actually, what we call PPH is the recognition of excessive bleeding that is considered worrisome by a skilled birth attendant. If it is more than 500 ml after, if it is more than 500 ml after normal delivery, we'll consider it to be a PPH. And moreover, if we should also look for, the amount of blood loss, which can be, sometimes we can use, we can measure the blood loss by measuring the soaked pads and sponges. And nowadays people also use calibrated under buttock drapes also. So by that we can diagnose it to be a PPH.
Okay. So you have already covered this, that a loss of more than 500 in normal delivery, more than 1000, or any amount of loss that causes a clinical deterioration of the patient. And we estimate by these 4 techniques: visual estimation, as you have said, calibrated blood collection bags. Now it comes with the Kellys itself. Deterioration like tachycardia, falling BP, pallor, oliguria, and hemoglobin estimation. If it can be done in the labor room itself, or if you have a 24/7 lab, that can be done. Now, this is the pictorial chart that we can have in our labor room above the delivery beds for prompt reference. This is a calibration bag. So, so how much do you think is the loss in this case, Swagata?
I think, of course, it is more than 500 ml because she is already having, as you have showed, she is showing signs of hypotension, tachycardia. So I think she has already lost more than 500.
So blood dripping to the floor is 2000 ml. 2 liters she has lost.
Okay.
So my next question is to Dr. Nilutparna. How do you classify shock, and in which category is this case? Would you put this case?
Yeah, thank you, Tanma. And in the beginning, I want to thank the organizers for giving me the opportunity. So the classification of shock. So I will use the classification of hemorrhagic shock, which is the Benedetti classification. There are 4 classes, class 1 to 4.
Yeah, for your aid, I will give you this.
Yes. So class 1 is when the patient will have blood loss below 750 ml. In this stage, patient will not have much clinical symptoms. There will not be much changes in the vital parameters, and her look-wise also she will be normal looking, and maybe she may appear slightly pale. Her urine output will be normal, respiratory rate, pulse, BP, all will be normal. And the second category is when blood loss is about 750 to 1500 ml. Here, the patient will have mild tachycardia. Pulse rate will be above 100, but it will be between 100 to 120. It will not be above 120. Urine output may be slightly less than 30 ml per minute. Her blood pressure, all like systolic blood pressure and her pulse pressure will be reduced. Then the third category is when the blood loss will be 750 to 1500 ml. Here her blood pressure will be reduced, her blood pulse rate will be 120 to 140. Urine output also will be reduced around 10 to 15 ml per hour. Up till this stage, till stage 3, these are reversible shocks. So with adequate measures, timely intervention, we can revert back the patient without residual damage. But the last stage, that is stage 4, which is irreversible shock, when the blood loss is above 2000. More than 2000
so this is quite an exhaustive classification. So very simple way to remember is maybe this, where we need to remember the blood loss. Here compensated is class 1, mild is class 2, moderate is class 3, and severe is class 4. And in the clinical symptoms, we need to remember the BP, where there is no fall in compensated. In mild, there is slight fall, 80 to 100, marked fall in 70 to 80. And in severe, there's profound fall between, systolic is between 50 to 70. So our case would be in which category, you think?
Actually, Chandra, I could, because of network issues, I could not hear the amount of blood loss and all the initial part.
The amount of blood loss we had calculated to be more than 2000 or 2000 ml. So it will be between moderate to severe. Moderate, we would think, yes. So my next question is to Dr. Hiren. How would you manage this case? If it were in your FRU and it started to bleed, what would be your first line of treatment? Dr. Hiren, are you there? Okay, would somebody else like to take this? Dr. Alok?
May I answer?
Yes, please.
First of all, thank you organizers for including me in this panel. So since this patient, as the history only says, she has many risk factors. She was a PIH case and she had an induced labor. And she had a difficult labor. So we have to be ready with all the active management. We should, we should think about that this patient is a high risk and she will definitely, she has all the chances of going into developing PPH. So we will be ready in our operating theater with blood transfusion facilities, and we will put 2 cannulas, white bore cannulas, with in case she requires blood transfusion, and we'll just alert our blood transfusion laboratory units for the required facilities which we might be needing. And active management of the third stage of labor has to be done in this case.
Yes, it was done.
Yes, and
so what would be your first line of management, as in bundle care? Could you elaborate?
Yes, definitely. We'll do the PPH bundle care in her case. Yes.
So I would just take you to this chart. So the first line would be to remember there's a very easy mnemonic, emotive.
Yes, we'll massage the uterus. We'll have to give uterotonic drugs. Then we have to give tranexamic acids. Then first of all, we'll give crystalloid solutions. And then, like, if required, blood transfusion. If required means this patient will require, because she has gone into a decompensated stage of shock. So she will require blood transfusion.
Yeah, so the important thing is that fluids, how much we will give, at least 2 bottles in the first 15 to 20 minutes. And we will continue with oxytocin. Your choice would be?
Carbetocin, definitely.
Carbetocin for the treatment of PPH is still a little controversial. It is for AMTSL more recommended, but we would go for oxytocin. 10 units in a bottle of NS at 60 drops. However, in this case, we can go for something else. because she was already getting oxytocin.
Yes, we can go for prostaglandins. That is
Yes,
prostaglandin will give.
And
Prostaglandin is a reserved drug for these kind of
yes,
patients.
because she cannot get methergin here. And
Yeah.
the new kid on the block is the tranexamic acid. So 1 gram can be given within 3 hours of the bleeding. And it can be repeated if the bleeding continues for 30 minutes or it restarts within 24 hours. So now we have done this and the bleeding has not, it is not controlled. Dr. Alok, would you like to take over from here?
Alok is having some issues on the net. That's why he has given a message. And don't forget the calling for the help. Don't forget that. You must ask for the help. That is the number one thing that you should do. And the PPH drill before you go for that. Okay, please carry.
Yes, we'll come to it. Dr. Hiren, if you are there, would you like to take the next question? This is a PPH emergency kit that you should be there. You call for help and you need to work as a team with prompt response and standard SOPs. So my next question is, if it is not controlled with these steps, what is the second step?
No.
Two.
I missed the first one. Can you please?
I have already showed you. It's bundle 2.
Yeah.
If it is not controlled with fluids, uterotonics, and tranexamic acid massage, then would you like to move on to something else?
Yes, we can go for this one. Hello.
Yes, you're audible.
Hello.
Yes, you are audible.
We can go for the bundle 2. That is,
Yes.
ma'am, can I just?
Yeah, please.
We can go for bundle 2. That is continuation of the oxytocin IV fluid. Yes. At first, we were giving, suppose 20 units, 60 drops per minute in a 500 ml of this one crystalloid, then followed by 20 units, 40 drops per minute in 500 ml, but not more than 3 liters. Then we can go for intrauterine balloon tamponade.
Yes.
And bimanual compression is very much important. With we have to inform the client about the bimanual compression because there are some difficulties. He can have some difficulty, and most important is we can go for aortic compression.
Yes. So here, what is recommended is that tamponade and non-pneumatic anti-shock garment are superior. They should be the first preference. In case you don't have these, you can go for bimanual compression and aortic compression, because with these two, it becomes very easy for referral and the patient will be more stable when you refer. Yeah. So these are the pictures of the tamponades. You can have a Buckley balloon if you have in your labor room, or you can make one with a condom. This is the anti-shock garments, bimanual compression, aortic compression. Oh, now I would like to go to Dr. Pranabika. Now, after managing, this patient reaches the tertiary center, your medical college, with her blood connected in an anti-shock garment, and she is still bleeding. There's still a trickle coming from the blood.
Yes. Good evening, everyone. Hello, am I audible?
In between, there was a little commotion regarding network issues. So we forgot to say something, that when you start with the bundle care, in this case, we should have done a speculum examination because she had a forceps delivery. We have to rule out a tear, and then the rest of the management continues.
Yes.
So there is, if there is a tear, it was repaired. Let us assume that it was repaired.
Yes.
And bundle 1, 2 has been done, and now the case reaches you in a tertiary care center. How would you take it over from here?
First of all, I would like to evaluate the cause of PPH. Excuse me. So cause of PPH, I would like to go to the basic that we need 4 things to be evaluated. First is the tone of the uterus. Second thing is the tissue status, if some damage is there. Then we come to the thrombin status, whether her coagulation profiles are okay or not, because since she is bleeding and she has been referred from a far place, so she may end up with DIC. And one more thing is trauma. So in this case, trauma comes the number one cause, maybe the number one cause, because she may have high up trauma because forceps delivery has been done, and that also after induction, after induction. So in after induction, if someone someone is doing a forceps delivery, there is heavy there is high possibility that she will have a rupture in the upper segment of the uterus. She may extend that uterine incision might that forceps delivery, there can be an extension of the tear out to the upper part, and she may bleed from that. So we have to have we should do a thorough examination, especially the tonicity of the uterus. And one thing we actually should remember is that whether the uterus is empty or not. If the uterus is empty, if there is no retained bits of placenta, it should contract actually, if there is nothing left, because it will contract if it is empty. So for the tonicity and the trauma part, in this case, we have to have a vigilant eye, because yes, if we have a bleeding up, then we have to go for a laparotomy.
Yes,
and the thing is, thrombi part, we need to evaluate properly, because we need to, if we see is bleeding for a long, we will need FFP or the FFP or platelet. So for that, we first have to evaluate the case properly for this 4 factors, 4 T's I am telling. So if we can evaluate that properly, then we will find out the cause and we'll treat the cause.
Yes.
We can say
now, if we find it to be atonic, then in spite of all this, we can go for compressing sutures, systematic devascularization, and a hysterectomy is our last resort if internal iliac does not save the day. So I will just go back to a quick recap on this picture. This is how it should be going. Bundle 1, uterine massage, crystalloids with uterotonics, tranexamic acid. Then, if it is refractory, we need to look for tears. We need to catheterize or empty the bladder. Explore the uterus for any bits. After that, we go for the second bundle. And the supportive measures are that she needs blood now. There should be a referral. And if not controlled, we go for surgical intervention. So I think everybody's managed PPH very well. And my last question is that how could we have prevented PPH? Now, is Alok still there, or can anybody else can take this? Swagata, would you like to take this?
For prevention, yes, ma'am. For prevention of PPH, actually, there should be readiness in every unit.
Yeah, in this case, how we could have prevented?
In this case, first of all, we should have a hemorrhage cart ready with with all the uterotonics, with all instruments and a checklist. And we should call for help. There should be a help response team, and we should always, in these cases, she was already mild anemic and she was hypertensive. So we should have kept at least one or two units of blood cross-matched we could keep.
We need to start from proper ANC and correction of the risk factors before antenatally.
Yes.
AMTSL and proper instrumental delivery.
Yes, and antenatally, the patient should have been ruled out about anemia correction, out anemia and correction of anemia, correction of hypertension.
Yes. And then general measures, like you have already said, prompt response and SOPs for PPH. PPH drills at regular intervals is very important. And timely referral. Yes.
Time and delivery should be done in a setup where there is a blood availability is there, and where surgical facility is there. And
that always is not possible, but then timely referral will help in those cases. So moving on to the next case. Mrs. Y, 32 years, gravida 2 para 1 post CS at 37 weeks, attended OPD for antenatal checkup. And to discuss regarding her delivery, her pregnancy was uneventful. She had done 3 ANCs in the PHC, and an anomaly scan at 22 weeks was there, which showed an anterior low-lying placenta touching os. There was no history of antepartum hemorrhage, and her hemoglobin is 8.6. My first question is to Dr. Rita. How would you evaluate this case?
In this case, she has already, she's second gravida with a history of cesarean section.
Yes.
And she is having moderate anemia also.
Yes. What would you like to rule out in this case, basically?
Ma'am, I will go for the mainly it is a low-lying placenta. Yes. So I will go for the mainly antenatally ultrasonography examination. I will want to know the extension of the placenta. Is it a what type of there may be adherence of the placenta to the cesarean scar also.
Yes. So you're looking for a placenta accreta syndrome.
Accreta, increta, or percreta. So definitely the ultrasonography will be helpful to rule out.
Ultrasound, you may see these findings. The normal uteroplacental interface is not there. So extreme thinning of the underlying myometrium may be there. There may be lacunae which light up on giving Doppler, and placental bulging into the posterior bladder wall may be there. My next question is to Dr. Swagata. Now you have this finding. Do you think you will go for an MRI also?
MRI is not always necessary, because a good skillful ultrasound, especially with a color Doppler, is gives almost a similar finding as MRI. So MRI, I don't think so.
So where MRI facility is not available, you need not sweat. Here we have it in JMC or in any college that you have it, and it is free of cost. So we do confirm, but it is not mandatory. However, it will tell you about the depth of invasion into the bladder, parametrium, adjacent structures. Now, how would you plan for delivery, Dr. Hiren? If this patient were to come to your center, how would you plan her delivery?
First of all, we have to know the exact gestational age.
Yes, true.
After, if it is preterm or term. Okay. If
when would you like to deliver her? At what gestation?
Before 37 weeks. 34 to 37 weeks we have to deliver, because there may be invasion of the tissue, as it is a percreta case. It can invasion of the tissue to the adjacent organs. So bladder is the most common. This one, as there is bulging also.
And where would you like her to deliver?
This type of patient has to be delivered in a very good tertiary care with all the multidisciplinary person.
So she needs a referral to a tertiary care center.
With at least a urologist and a surgeon to be there during the operative procedure.
So moving on to the next question, preoperative preparation. Dr. Neetumani Gogoi, would you like to take this? How would you prepare this case if it were to come to you?
Okay, so since this patient had moderate anemia again, so we will like to rule out any causes of anemia if she is having. And then, as my previous moderator panelists have already mentioned about the location and the invasion of the placenta, to rule out if this patient has any placenta accreta percreta, so that we have to rule out. And then about the other general status of this patient, we have to take a good care of her, and so that she doesn't develop any other risk factors during her antenatal period. And
how much blood would you like to store? We also need to correct her hemoglobin antenatally. Yes. You would want a hemoglobin of how much prior to surgery?
At least 10 gram percent. She should achieve that level. Yes, and we have to keep blood stored for
how much? How much would you like to keep?
Deliver. Well, 2 units is, I think, is the minimum.
4 to 6, not below that. And party counseling is very important in this case. That she may land up in the ICU. She may land up with a hysterectomy. There may be morbidity, long hospital stay, ICU. And the pre-anesthetic checkup.
Checkup is also.
The anesthetist has to be in the loop in this. Okay, moving on. Next question is Dr. Alok. You have taken. Are you there?
Yeah, I'm there. Am I audible?
Yeah, you are. Alok, so you open up this case. You being a very expert surgeon, you have dared to take on this case. And on opening up the abdomen, you see this. Okay.
Okay.
What is the diagnosis? Possible problems that you are anticipating during surgery?
Okay, just give me a brief outing. I just reached home. That's why I could.
Okay.
What was the case?
Yeah.
Just
brief you.
No, just give me you don't have to go to the slides.
Okay, she's a 32-year-old post-CS at 37 weeks who came to the OPD to discuss about her delivery. She had an uneventful pregnancy. She had only 3 ANCs. She has a 22 weeks ultrasound, which says it is a low-lying
placenta. Okay.
Anterior placenta touching os. She has no history of APH and her hemoglobin is 8.6. You can take it over from here.
Fine. At 22 weeks, low-lying placenta, difficult to say that at term it will be a placenta previa. That is a self-assessment. Even in placenta previa, if someone is not bleeding, we still want to wait till labor or she has some bleeding, then only take a decision. We have had cases with some marginal placenta also, we could have gone for normal deliveries. So this one is, if I'm not mistaken, in this picture, it is somewhere in the fundal part. There's a
no. This is the lower segment.
Oh, this is the lower segment.
This is the lower segment. There's a bladder fat visible.
Okay, so there's a means it looks like a bladder hematoma.
Yeah. No, it's a bulge in the lower segment, and there are prominent vessels.
Okay, so we've opened her up.
So this is a Preeclampsia, basically. Let me tell you. So what are the problems that you will anticipate?
Okay, definitely we'll have massive bleeding.
Right.
We will have to have a decision.
Correct.
So the moment we have opened this, probably I will get my entire team ready and say this is going to be a catastrophe. Be ready with all the team. We might even hold on for some time if she's good, that we can hold on before giving the incision. That get the entire team ready.
Could you just tell us what are the problems or what are the things that you are anticipating?
First, once we open the uterus, we separate the bladder first. Then only some bleeding might start. Once we give an incision, then only she might start bleeding. We might have to go through the placenta also at times.
So she may have a life-threatening PPH. Absolutely. She may land up in a hysterectomy, as you have said.
Absolutely, yes, absolutely.
There may be injuries that could from here.
All these in mind. So this is a team effort. It should be a team effort. We tell our anesthesiologist immediately. We tell our blood bank the blood should be ready. Everything ready. Even we have not delivered the baby room. The pediatrician should be around. Yes. Our first priority will be the mother, but we are also taking care for the baby. Our first idea will be to safely deliver the baby, and then at that moment take a decision about the uterus.
Yeah, just so I will move to the surgery, steps of surgery. How would you proceed with surgery, Pranambika? Just tell me briefly the steps.
Yeah, in this case, how I would like to go is, I would like to go in a longitudinal incision because longitudinal incision. I will open up the abdomen. Then first I would like to go for prophylactic internal iliac ligation, or I'll take out the baby with a classical section thing, and I will not ask the anesthesiologist to give any uterotonic. I don't want my placenta. I don't want my placenta to get separated. I want the placenta. I will just clamp the cord and I'll just stitch the uterus in the longitudinal classical section. Then I will proceed for hysterectomy, which I'll be taking in advance. I will be taking the consent for hysterectomy, because in this case I am expecting massive hemorrhage and I cannot save the patient if I don't do hysterectomy, because I need to take out the lower segment of the uterus and I have to go for a total hysterectomy. Yes, so that I have to go for it.
Okay. So there any conservative management? There is, but today we will not go into it because we are running late. Now, if this case is going to need massive blood transfusion protocol has to be in place. So Dr. Nilutporna, would you like to tell us what this massive blood transfusion protocol is, or what is massive blood transfusion?
Yeah, massive blood transfusion is defined as like more than 10 units of blood transfusion in 24 packed RBCs in 24 hours time, or replacement of whole blood volume in 24 hours time. Mm-hmm. So like this cases, placenta percreta may need massive blood transfusion, and in actually different ICUs follow different protocols, but commonly used protocol is for every 6 units of packed RBC, the ratio of RBC, FFP, and platelet is 1:1:1. So that protocol is followed.
Okay. That's great. Now this is an open question. How can we prevent Percreta-Equita syndrome and its complications? Because this is a menace now, because so much of cesareans are happening. Anybody would like to take this?
Yes, hello?
Yeah,
am I audible? Yeah. In early pregnancy, actually we should look for the position of the sac. if it is in the scar, this is bound to go for an eccrita, or there in the lower segment implantation of the sac in early pregnancy, and with a Doppler, if we can see the invasion or implantation in the lower segment. So we have to counsel that you might end up with this type of complications. So
Now, this is after the pregnancy has happened. To prevent, we need to reduce the primary cesarean section.
Yes.
Dates and proper screening in any post-CS, adequate pre-op preparations to reduce PPH, and preoperative ureteric cannulation can be done if required to reduce injury. Now, moving to the third question, Mrs. Z, 28 years, para 2, on day 20 LSCS, presents with bleeding PV. Uterus was 16 week size, contracted. On examining, vagina was full of clots, cervix was normal, trickling seen through os. The pulse was 104, BP 110/70, no history of fever. Her hemoglobin is 7.8, and her total count is 23,000. Neutrophils is 90%. Now, anybody can take this. What are the possible causes in this? This is a secondary PPH, right? So, what may be the causes of secondary PPH?
Ma'am, can I say?
Yeah, please.
The most important cause of secondary PPH is uterine infection.
Right.
So in this case, we have already seen the total count is 23,000. So probably it is there is infection. So most commonly endometritis. Then there might also be retained placental bits, which is another cause of secondary PPH. Again, there might be abnormal or subinvolution of the uterus, and sometimes there may be coagulopathy also, and and sometimes cesarean scar rent.
Dehiscence may be there. So rare cases are AV malformation and choriocarcinoma, but we will stick to the more common ones. So what are the risk factors in this case? Out of these, we have infection and subinvolution, right? Okay. Now, how would you evaluate this case? Anybody? I'm keeping the third case open. Whoever wants can take it. Or we will
this case we can do an CRP, we do a CRP, we do a procalcitonin to see how much it is. We do a scan, we get an idea. Put in on antibiotics, it is a decision making. We go for the small, we have to open the os and take out the products probably.
Right.
And
so an ultrasound will tell us about the placental tissue. If there's a rent or dehiscence, AV malformation, you can see a sepsis screen. How would you manage this case? Open to all, anybody can take it.
It all depends on the AV malformation. If we expect,
so we are leaving out the rare causes here. We are leaving out AV.
If subinvolution and if there is some pus collection, we can very well drain it. We can do a small dilatation and we can drain it out. But we have to be very cautious because it's day 20 of CS.
Okay.
So we can do that, but eventually antibiotics will suffice.
Yes. So there has to be an exploration of the uterine cavity. If there's any bits left, the antibiotics and 2 units blood transfusion was done. Patient had another bout of bleeding 5 days after this. Now what? Anybody?
You have to rule out any coagulation problem with this.
Yeah, that is a possibility. Anything else?
Any trophoblastic disease.
Right. Scar dehiscence because of the infection. And subinvolution also, some of the modified spiral arteries open up in the bed. So a laparotomy and repair of any rent, if any. So everybody is wonderfully managed PPH in a primary PPH case, in a difficult eccrita case, and also secondary PPH. I thank all of you for this wonderful session. And just to end it all, how can we prevent PPH, secondary PPH? Any inputs? Okay, I'll give it.
Hygiene, proper counseling of the patient regarding the hygienic measures she has to take after getting discharged from the hospital is very important. Apart from taking the regular medicines, mostly antibiotics she has to take. Otherwise,
prevent infection. Yes.
To prevent infection.
So, if it is a normal delivery, we do not explore the cavity. Number one. But if it is a cesarean, a digital exploration of the cavity can be done to rule out any placental bits. And we need to check for the completeness of placenta and membranes in normal delivery as well as cesareans, and proper closure of the uterine cavity in 2 layers. And with this, we come to the end of our session. We are 10 minutes behind schedule, so sorry for that. So let's save mothers and stop PPH. Thank you so much.
Thank you,
Dr. Tanya.
Tanma, for wonderfully conducting this session. And I thank all the panelists for, we really had a very wonderful discussion and we really enjoyed. So now with this, we conclude our scientific session. And now I hand over this session to Dr. Indrani Roy to conclude the session with vote of thanks. Dr. Indrani.
Thank you, Deepti. I think we have come to an end of this session today, and to deliver the official vote of thanks. It gives me immense pleasure to deliver the vote of thanks for this event today. At the outset, my sincere thanks to Professor Gokul Chandra Das, who has honored this webinar with his inspirational thoughts. I would like to thank Dr. Arun Madhav Barua sir, our guest of honor, for sparing his valuable time to be with us today. My sincere thanks to our speaker, Dr. Sadhana Gupta ma'am, Dr. Puroshri Sharma. Thank you for such a wonderful deliberations, and indeed we have learned and gained a lot today. My sincere gratitude to our chairpersons, Dr. Shashwati Sanyal Chaudhary ma'am, Dr. Nilakshi ma'am, for being with us today and sharing their thoughts. I would like to thank our moderator, Dr. Tanma, for an excellent moderation of this topic. We know PPH is such an important topic, and thank you, my esteemed panelists, Dr. Alok, Dr. Nilutparna, Dr. Nitumoni, Dr. Pranabika, Dr. Hiren, Dr. Swagata, Dr. Rita. Thank all of you that you have been with us today and you have spared your valuable time. And I thank Dr. Deepti Goswami, my co-convener today, who has helped me in organizing this webinar. And thank you to the SHIELD team for taking care of the logistics for this event. And last but not the least, I would like to thank all the delegates who have been joining this webinar today. Without your presence, this event would not be successful. Thank you all, and till we meet again, thank you everyone.
Thank you so much.
Thank you.
Anything
Bye.
the
Good
SHIELD
night.
team wants to
Bye.
say anything, the SHIELD team, if they want to say anything, this we will close.
Thank you so much for your opportunity, ma'am. Nice webinar, nicely organized. Thank you so much, ma'am.
Okay, thank you everyone.
Thank you, everyone.
Thank
Bye-bye.
you.
Bye.
Thank you.
Thank you.